Our second speaker is Mrs. Baubre Murray. Barbara is a trustee of Crohn's Colitis New Zealand. She's a chartered accountant and she went as a patient representative of our group. So Barbara, tell us about Barcelona.
Thanks, Brian. Actually, I should add that I did go earlier this year in February to Barcelona at the invitation of Abbott's, so thank you very much, Abbott's. But I'd have to tell you that it was actually Brian that was going to go originally, and unfortunately his son was getting married that week, so I drew the short straw. What happened was that there was two things happening. There was a medical conference, that's the ECCO one that John was talking about, so that's the grouping of all the European medical specialists, so they have their own grouping called European Crohn's and Colitis Organisation. And like we have Crohn's and Colitis here in New Zealand, there's one in Australia, Crohn's and Colitis Australia, America, Canada, and if you can imagine across Europe there's 27 of them. So what they've done in Europe is they have developed an umbrella organisation called EFCCA, which is the European Federation of Crohn's and Colitis Associations. And what EFCCA decided to do was they felt that by having all these members, so they've got about 100,000 members across the 27 countries, and they felt that really what they needed to do was find out what patients felt and how patients were feeling. It was all very well knowing about what was happening on the medical side, but what we really wanted to know was what was happening from a patient perspective, how they felt. So about a year and a half ago they decided to do a survey, to survey their members and see how they actually found things, what their treatments were like and things like that. And it wasn't a statistical survey, because to do a statistical survey you need to know your population size, you need to do it randomly and this, that and the next thing. What they did was they just did an online survey, so it was an opt-in. They invited members to give their views. But I'd have to say that when they got 5,000 responses, you'd have to say that that's a pretty strong number to actually draw some conclusions from. And what we'd like to do here is to do something similar to find out, what the incidence, how patients here feel as well. 7 weeks before the conference, EFCCA organised with Abbott, so only 7 weeks out from the ECCO conference, they decided to launch the survey results the day before the conference started. So what they did was they invited patient groups to send a representative, and Abbott's here in New Zealand and Abbott's in Australia sent a representative over. The launch was held at the Olympic Stadium in Barcelona, which is where they held the Olympic Games in 1992. And as John said before, there was a general theme, because it's an Olympic year this year, the Olympics are going to be held in London, a general theme of let's pass the bat and join the fight against IBD. And this is the photo they took of all the representatives from around the world, and there I am. The survey was for across 27 countries, covering 100,000 members. And I think it was actually quite appropriate that ECCO, the medical conference people, organised and asked EFCCA to present the results of the survey for their medical practitioners, so they could actually know what the patient perspective was. And Ben Wilson, he's a Crohn's patient from EFCCA, and he was involved in the survey, and he was the person that presented the results at ECCO. And I really wanted to reiterate the comments that he made when he said he wanted to thank the medical community, the IBD nurses, for their general interest and passion towards finding a cure and finding the cause of IBD. We're the ones that get the benefit of that, and he wanted to thank everyone, and I reiterate that comment too. Professor Peter Gibson, who you might know as the FODMAP expert from Melbourne, was over here talking at the GP's conference here in Wellington last week, and he said that the medical students coming through are just flocking to do IBD because it's really exciting for them, because there's no known cause, there's no known cure, and they really want to be part of this exciting thing and try and, I guess, find the answers. So that was really quite surprising to me and really pleasing at the same time. And then when you hear people like Richard Geary and that, he talks about how much he loves looking at bowels all day long. I've never heard you say that, John, but do you know what I mean? To hear this passion with which some of these medical specialists and nurses and that, the way they look at our disease, I think it bodes really well for us for the future, and we're very, very fortunate. So I'd like to join in thanking the medical community for their interest. The survey, there were 3 real aims for the survey. They were to obtain an international perspective on the patient perception of the quality of healthcare they were receiving. looking at their access to healthcare, the support services across the countries, and trying to understand better the differences between age, gender, countries, and the different types of IBD. So of the 5,000 responses they got, 2/3 of those were from women, 1/3 from men. They came from 22 countries across Europe. Nearly 70% were between 19 and 44. 2/3 had Crohn's disease, and 1/3 of the respondents had ulcerative colitis. So what we're doing is just setting a bit of a scene for who was responding to the survey. But the general themes that they asked about, the online questionnaire was covering 53 questions across 5 general themes. So what was your experience? There was 5 questions about things like the length of time for your diagnosis, 10 questions about your healthcare, so what medications you're on, whether you'd had surgery, those sort of questions. 18 questions of the impact of IBD on your life, so what's your current state? Are you in flare? Are you in remission? Are you working? And then 9 questions about the work impact, so do you have much time off work? Do you experience discrimination? And 7 overall life impacts, so what has been the impact for you on your career path, relationships, and then another 4 questions about age, sex, where you live, and employment status. So those were the sort of questions they were asking. There were, I guess, several key result themes that came out. First of these, for me anyhow, was the importance of timely diagnosis. It makes a huge difference. We're going to talk a bit more about these as we go through, but the key result themes were timely diagnosis, the importance of good access to specialist care, and the need for a holistic approach to the whole care. What they're saying is that it's not just enough to treat people, it's not enough just to give them medication. You need to look at that bigger picture, their whole life, and the impact and the quality of their life. And if you want to go and have a look at all the results, you can go to www.efcca.org. They're all on there. So, in terms of general diagnosis, ulcerative colitis appears to be diagnosed much more quickly than Crohn's disease or indeterminate colitis. And that's probably pretty obvious in terms of indeterminate colitis, because that's the one that no one really knows quite what it is. 70% of people saw a specialist within the first year of their disease, and nearly 50% within 6 months. The majority received timely diagnosis, so 54% within a year, but 18%, so that's nearly a fifth of all the people in the survey, waited for over 5 years before they got a diagnosis. And 64% needed emergency care at least once before they were diagnosed. So what that's telling us is that people are turning up at emergency departments, and that's the first time that they are being considered. So they might have been to GPs in that first, but it's only when they get to the emergency department, they're really bad, that someone really starts probably taking notice and getting them to see a specialist. This is what some of the respondents said. One of them said, "I went to A&E in serious trouble. I came out 2 weeks later with my diagnosis. I was worried all the time it was cancer." And another one said, "My diagnosis took over 5 years. I missed my teenage years and only got my life back as an adult. I knew I didn't have an eating disorder." That's what she said. So the general recommendation for diagnosis is timely diagnosis, so timely access to specialists. There's UK IBD guidelines supporting access to IBD nurses and clinics, but what we really need to do is get people to specialists really fast. Peter Gibson was saying last week that his research that they do in Australia says that the best outcomes are achieved if they, and he's called it, hit it fast and hit it hard. And that really relies on timely diagnosis, getting onto it quickly, and throwing a lot of probably biological medications at the disease to get the best outcome. So it's really important, if you look at it that way, that how important the timely diagnosis is. Also what we need is better access to the specialists, so probably what we need is we need to get the patients acknowledged and recognised by the GPs, so we need to educate the GPs. At that conference, most doctors, most GPs said that they were lucky if they had 2 or 3 IBD patients in their whole practice. So as you can imagine, if they've only got 2 or 3 at the most, then it's very, very difficult for them to give an accurate diagnosis. So what we're recommending is that maybe they work off a checklist, so like they use in Christchurch, have a checklist that helps them sort of better define who might have IBD, get them along to a nurse's clinic, perhaps at the hospital, The nurses at clinic will have a much better idea about, the state that someone's in, and then get them referred much more quickly to a specialist. So there's probably a bit of an improvement in process there, and also some sort of education for emergency departments, maybe a checklist too. And you were talking about that, John, about having specialists in the emergency departments and the difference that that might make. I think it might be a whole lot easier and cheaper if they just had checklists, actually. General health care and treatment. 70% said they're satisfied with their treatment plan, and 73% were happy with their surgical outcome. This next part I find absolutely fascinating, because I guess when you live somewhere like New Zealand, you always wonder how everyone else is being treated in the rest of the world. So this is what this is what's happening in Europe, this is what the survey found. 6% are not currently taking any medication. Now, I'm not 100% sure whether that means that they don't need to take any medication or whether they're not taking their medication. I think it probably means that they're not on any medication. 47% were taking the 5-ASA type medications like Pentasa. A third were taking immunosuppressants like azathioprine. Nearly a third were taking the biological drugs like Humira. Just over a fifth were taking steroids like prednisone. And 1% of the respondents had no idea what they were taking at all. So if you add all that up, clearly some people are taking more than one, because that adds up to more than 100%. So it's possible that people are probably taking maybe prednisone with Pentasa or something like that. So often there's a combination of medications that people are taking. Interestingly, the feeling we've always had is that steroids weren't particularly good for you, and by preference the idea was to move people off steroids. Interestingly, 52% have used steroids. Now remember, that might be people that have had IBD for a long, long time, so maybe they've had steroids in the past, maybe they're not having them now, but certainly over half the people have used steroids. 42% have experienced side effects. Nearly half are concerned about the long-term effects on their health, things like osteoporosis. But 28% still keep steroids in hand in case of an IBD flare. It's almost like their trusted friend. Information on associated conditions. So half the people have some sort of joint problems associated with their IBD. A third have some sort of skin problem. Nearly a third regularly take painkillers to relieve their IBD symptoms. I'm surprised that wasn't a lot higher personally, but anyhow. And 15% have had complications of surgery, such as adhesions, wound infections, or pain. On the hospitalisation surgery front, 85% have been hospitalised in the last 5 years. To me that seems really, really high. 89% of those are with Crohn's disease. But only 40% had had surgery, and that's maybe going back to the point you were making, John, about you turn up in an emergency department, they don't know what to do with you, so they just admit you, to start off with. Those under 18 had fewer operations. 45% of those aged 55 or older had had at least one. Look, part of that can be explained just by an age thing. If you're 18, or if you're 45, you're much more likely, if you're going to have an operation every few years, to have had more than someone who's under 18. So to me, I don't know if that tells us an awful lot. But only 13% of UC ulcerative colitis patients had had an operation. So on the communication front, 88% of the respondents have access to a specialist gastroenterologist. 45% of them have access to a nurse who specialises in IBD or has a special interest in IBD. In New Zealand, I don't think you can train as an IBD specialist nurse. I think you can do so in Australia and the UK and overseas, but certainly not here. So sometimes what we've got here are people that have a special interest in IBD. 53% said they didn't get to tell their specialist something really important. And 65% said they wish their specialist had asked more probing questions. Here's a couple of comments from respondents. They said, one of them said, "In my mind I have a list of questions, but things always go differently when I see my doctor." And I think a lot of people can probably relate to that. That's why doctors often suggest that you write your list down. Another one said, "IBD is humiliating. I hate feeling so vulnerable. Discussing it's bad enough. Then there's the examinations." And I think most people here could identify with a lot of the comments that people were making over there. So healthcare recommendations, what they'd like to see over there, and I think we'd like to see here, is consistent medical treatment across all countries and parts of the country, so it doesn't matter where you live, you know that you're going to have the best treatment available. Looking at using some of the newer therapies, because the cost of not having you in hospital might make it worthwhile, offset the higher costs, and that's the point you were making too, John. Keep the steroid use within general guidelines. So in Europe it's the ECCO guidelines, and I'm sure we have some local guidelines here too, definitely some for the UK. Use the IBD nurse clinics to increase access and time available for improved communications. So what patients were saying was when they had a nurse, they tended to have more time that they could talk to the nurse. And maybe it's the nurse that asks those more probing questions to solicit more information, so that by the time the specialist gets to see them, they can really focus their time. And the patient will feel that they have actually provided all the information they need to. Another recommendation was to consider the overall health of the patient and refer them to other specialists. So it's about acknowledging that it's not just necessarily an IBD problem. There might be need for dietitians, psychologists, the use of other specialists along the way. And recognising that the health management plans for each patient should include assessment and management of the 3 key symptoms: fatigue, that's the tiredness and the iron thing that you were talking about, John, the urgency, so the need to go to the toilet, and pain, as well as treating the disease. Impact on life. 50% of the respondents are fighting active disease today. 96% feel tired, weak and worn out during a flare, which isn't probably that surprising. What's really surprising is that even when they're in remission, 83% still felt that way. To me, that's huge. 49%, so half of the respondents, reported that their life was significantly affected by IBD. And some of the impacts included the effect on plans. So people would change their plans because of their IBD. They wouldn't make any plans. They wouldn't go out the door. They'd plan all their routes to be aware of where the toilets were on the way. They'd time a long journey to take breaks. All those sorts of things. One person said, the tiredness is overwhelming. It never has gone away. And I think I'm pretty well. It doesn't matter how much I sleep, it will never leave me. So again, that goes back to the point about the iron, I think that you were saying, John. Maybe we need to be looking at getting these faster infusions of iron for patients. Impact on work. 74% of people have taken time off work in the last year, purely because of their IBD. Of these, a quarter had had more than 25 days off. That's 5 working weeks. I don't think anyone really has that much paid sick leave. So some people just work part-time. A quarter of the people reported receiving unfair complaints or comments about their performance purely because of their IBD. And 21% experienced direct discrimination in the workplace because of their IBD. Over half agreed that their work prospects had been negatively impacted by their IBD, and 36% of them said strongly. Overall, when we look at things like relationships, when they're asked about relationships, and I am just summarising some of the information here, 40% feel that IBD prevented an intimate relationship, and 34% feel that IBD caused one to end. This is what one woman said. My boyfriend just couldn't handle the fact I have an ileostomy. We're not together anymore, and I was devastated, but it showed his true colours. On the education front, over half felt negatively affected. On the toilet front, 66% worry about toilet availability. And this is quite incredible, I'm not sure how they asked this question, but 20% said that they had to be rude to people to gain access to a toilet. And that's probably why when we launched Crohn's and Colitis New Zealand nearly 2 years ago now, one of the things we did was develop the Toilet Map website and up the iPhone app for toilets too. So recognising that people did need to know where toilets were and making it easier for them to locate the nearest toilets. Sleep. IBD pain woke up 40% of respondents while they were sleeping. So that's not going to help with your fatigue and that if you're getting woken up at night with pain. Nearly 40% said meeting other people with IBD made them more optimistic, and 63% of those who joined a patient group like this one, Wellington Crohn's and Colitis, found it beneficial. The least likely to be engaged with groups were those aged 19 to 34. And I think we've sort of dealt with that quite well by setting up our Facebook page. We've got about 900 people who like our Facebook page. So life impact recommendations. We think we need to encourage specialists to refer patients to support groups, And I'm not saying that you don't do that, but we need to make sure that we keep specialists supplied with materials so they know where the support groups are, how to access them. We need to support access to therapies to reduce time off work, and we need to advocate to avoid work discrimination. So, as a very quick summary, so I've just sort of really skimmed over the whole survey results. But as a summary conclusion, I think we can say that the results of that survey show that IBD has a huge medical impact, but it also has this huge social impact and a huge social cost. So where to from here? Well, as we said before, we need timely diagnosis. So we need to improve GP and ED awareness, so emergency department awareness and education to recognise IBD. Perhaps that's by using the checklists, sending prospective patients through to IBD nurse clinics, and for them to then do some more screening and filtering to get people through to see specialists as soon as possible. We want specialists to consider the overall health of the patient and provide assistance and referrals to other health areas where they're needed, and to local patient groups. We need to provide local patient groups, and we need to advocate towards consistent access for all patients to the newer medications, where the costs being off work and hospitalisation and that make the higher cost of these medications cost effective. To be able to advocate for these things, we need our own impact survey result, and we need to know the costs associated with the burden of disease for our patients. We can find out more about the impact of IBD in New Zealand by inviting people to do exactly the same survey, but getting good figures on the financial burden is a huge project, very, very expensive, and we'd love to do it if we could get the funding to do it. But if we knew that, then we can go to the funding providers and say, this is the cost of having patients with IBD, the benefits of the better medications that are going to be well worthwhile. So that was really the results of the visit to Barcelona. I felt that it was really sort of interesting to hear what was happening over there. I thought our results are probably likely to be similar. I'm sure many of you identified with the findings that they found over there, and I really look forward to having some results of our own. I'll pass over to you, Bob.